Hi, everyone. I'm sure people will continue to join us over the next minute or two, but I'll go ahead and get started with just a few housekeeping items. So welcome to another semester of our K-CART seminars, first one of our fall semester. We're going to be running these just the same as last year, so we're planning on all of these being over Zoom. And just like last time, we would love to have your videos on if you feel comfortable, but we do ask that you stay muted during the actual presentation. If you all have questions, you're welcome to send them over chat, and those will go directly to me, and you can do that at any point during the presentation. But you can also feel free to unmute yourself at the end of the presentation and ask questions yourself at that point. And as a reminder, I sent out the schedule about a week ago for the talks that we'll have this semester, but coming up in about a month, our next talk will be October 14th, and we'll have Dr. Rebecca Hacker. She's coming to us from KU Juniper Gardens Children's Project. So we'll be looking forward to that in about a month. And today we have Dr. Anjana Bhat from the University of Delaware joining us, and Matt's going to give you all a little bit of an introduction for her.
All right, thanks, Shannon. So it is my pleasure to introduce Anjana Bhat. Anjana, it's so good to have you here. I've known you for years, and so I've always enjoyed your talks and looking forward to this one as well. So for those who don't know, Dr. Bhat is an associate professor at the University of Delaware within the Department of Physical Therapy. Her research program focuses on relationships between motor development and other key clinical issues in autism spectrum disorder. Interestingly, her work really spans multiple disciplines within motor development of autism, including characterization of motor phenotypes, analysis of biomarkers related to motor phenotypes in autism, as well as interventions, which are rarely discussed and studied in the context of motor impairments in autism. So I'm very excited to hear more about her most recent work. Anjana is someone whose program of research I followed for years because we have an overlapping interest in motor development and autism, but also really because she's been a leader in the field and trying to advance attention to and understanding of this area of impairment in autism, and really trying to understand it in the context of whether this is a core feature of autism or how it relates to core features of autism, and then trying to have a real clinical impact by building and studying treatments around this core domain of challenge amongst individuals with autism. Anjana has been funded by Autism Speaks, Cure Autism Now, so she's old like me and can remember when Cure Autism Now was around and was funded by them, as well as by NIH throughout her career, including a newly funded NIMH R01, which is very exciting, looking at motor and other phenotypes in autism in the SPARK cohort. So I'm really looking forward to this, Anjana. Welcome to KU via Zoom. Hopefully we'll get you here in person sometime soon. And you are free to go. I'm looking forward to hearing about your work.
All right. Thank you, Matt. And thank you for this opportunity to speak to this wonderful group at K-CART. As Matt said, a lot of my work is sort of along the veins of what Matt does, and so I might, at some points, you might feel like I'm, speaking to the choir. You already know why some of these issues are important, but hopefully there are some new ideas in terms of interventions and also FNIRS-based biomarkers. So in terms of my background, I am a pediatric physical therapist. I have a bachelor's and master's in physical therapy. My master's was focused in the area of pediatric neurology. This was in Mumbai, at the University of Mumbai. And I came to the US for my PhD in movement science to the University of Delaware. So this is where I got my degree And when I was finishing up, I was really interested in applying my understanding and framework in motor control and motor development in young infants to a clinical population. And so that's when I came across a postdoctoral fellowship with Rebecca Landa and Stuart Mostovsky at the Center for Autism at Kennedy Krieger Institute. And that's where I was first exposed to this field of autism and motor issues in autism. And that has been such a fascinating topic. I've stayed in this area until now. After I finished my postdoc at Kennedy Krieger, my first job was at the University of Connecticut. And so that's where these intervention studies started and have continued. I was there for 6 years and then moved to University of Delaware. So these intervention studies have continued from there to when I have been at, since I've been at Delaware. And I've also worked with Kevin Pelfrey. So my sabbatical year, I worked with Kevin Pelfrey to understand how to use functional near-infrared spectroscopy approach to studying the brain in children with autism. And that has continued at the University of Delaware as well. So that's why I'll be talking about some of the motor difference studies done with the SPARK study team. These are more recent studies, and then the interventions that we have examined over the years, and then also the work I have done with Kevin, and then later continued at UD in developing biomarkers, FNIRS-based biomarkers. All right, so the first thing I would like to do is thank the people involved in this research. There were, definitely our children and families are the most committed group of families who, again and again come back to participate in different tasks and different studies. So we are really fortunate to have this population and group of families to work with. Graduate students, there are several, but the 4 that I would definitely like to name here are Sudha Srinivasan, whose dissertation work was on these music and movement studies, who's now a faculty at the University of Connecticut. Maninder Kaur, whose dissertation was in the use of yoga for children with autism in that intervention study, and she's at the MGH Health Professions Institute. Wanchan Su is my current doctoral student who's finishing up, and a lot of her NIRS work is actually discussed here and is part of her dissertation work. And Corina Cleffa is another second-year student who will be doing a lot of the intervention work as part of her dissertation. Also my collaborators, Dr. Eichste, Dr. Pelfrey, and Overby, who have helped with the ideas related to these studies. The SPARK study team, so SPARK is one of the largest studies in the US following the development of children with autism, and they've been very generous to share their data. And so today, the first third of the lecture will actually discuss SPARK data and what I have noticed in their data, and then definitely the funding sources as well. So there are 3 areas I will talk about. The order is a little different than what I had sent in the mini abstract. I'll first start with motor differences, then go to motor interventions, and then go to social motor biomarkers. So why study motor in ASD? As I said, I'm preaching to the choir. You know that ASD is a multi-system disorder, but when you look at the definition of ASD within the DSM, it is couched as a social impairment. And only recently were sensory symptoms added to the repetitive behavior category of the definition of ASD. And motor is still absent. Other comorbidities like cognitive and language impairments are part of this definition as specifiers. And motor, again, is outside of all of these different aspects of ASD definition. So originally, when I was doing these studies, say at Kennedy Krieger, and then later at UConn and UD, I had really small samples to work with. These papers are out there where we've looked at praxis, we've looked at coordination, fine motor, gross motor, but the sample sizes were small, 20, 25 children. And we would see differences in motor performance between children with autism and typically developing children. But this was the first time when I worked with the SPARK team, I was able to access a large data set looking at motor performance in children with autism. So the SPARK study is mainly a series of questionnaires that have been filled out. So they are not assessments. For a large sample like 20,000, 16,000 families, it's hard to assess all of them. And so this is where they have started. And the hope is that as you access the participant match, system that they have, which allows you to recruit families in your studies, more and more motor data will become available. But at this point, what they have in everybody is this developmental coordination disorder questionnaire, which I was surprised to see that they implemented in their whole sample. And so in this sample, I was able to filter out data that belong to children who might have other comorbid issues that might lead to motor problems. So birth defects, cognitive impairment, perhaps. We have tried to remove that out, and we were left with 11,000 or so children, 12,000 or so children. And yet the risk for motor impairment did not change. So if you look at this sample or this sample, both of those samples are showing high levels of risk for motor impairment. That's what the DCDQ screens for. But when you look at whether they also hold a dual diagnosis of DCD, only 15% hold it. So if motor issues are not discussed within the definition of ASD, the other provision that DSM provides is you can give a co-diagnosis of DCD. And that is really not being used right now. Only 15% of this population has a co-diagnosis of DCD. If you look at the services they receive, 80% receive speech and OT services. OT mainly targets fine motor and sensory issues. Gross motor issues are not as much addressed in this approach. And if you look at the other therapies that are provided, physical therapy or recreational therapies, those proportions are much smaller. And so the overall finding here has been that motor issues perhaps are underdiagnosed and undertreated in children with autism. Another thing I looked at is how this changes over development, and what you see is these issues don't go away. You would think that the motor problems would go away, and that's not what the parents are reporting. There are persistent motor issues even at 15 years of age, and 5 to 15 is the age range in which you can administer the DCDQ, and that's what has been done by the SPARK team. And so I don't have data above that, but that is something people should look into, whether these problems continue to remain in the future. The other thing I want to say is that the DCDQ has 92% positive predictive value. That means 92% of this sample will actually present with a motor impairment once you administer a motor assessment. The positive predictive value was tested against movement ABC, which is a standardized motor assessment. So therefore, I think given this finding, motor should be considered within the definition of ASD in a future revision, may be in the criterion or the specifier. In both places, this could fit. Where should it fit ideally? We'll talk about that in a little bit. So the next thing I did is categorize the data of this whole SPARK sample. So as I said, they collect a variety of parent questionnaire data. And so all of these families had a social communication questionnaire completed and a repetitive behavior scale revised completed. And so based on their individual score, they were categorized into very low, low, high, very high, and extremely high categories for social communication impairment or repetitive behaviors, severity. And so this was just based off of these ranges using standard deviations and means of the entire population. And then the next thing I looked at is the other delays, so general delays that are not related to core impairments of autism. And not a lot of children have IQ measures or more robust assessments. There are small samples that have that, but the more global measure that they had were parent-reported delays of parent reporting whether their child has a cognitive delay or a language delay or a functional delay, where they are asked, okay, is your child's cognitive ability at or above peers? Is it slightly below peers, or is it significantly below peers? And so accordingly, I categorize them into these 3 subgroups. And so what you see in these subgroups within this vast sample is the orange bars are risk for motor impairment in these subgroups using the DCDQ total scores. And what you see is a proportion of those subgroups that actually present with motor impairment. And you see that that proportion increases as social communication impairment increases, as repetitive behavior severity increases. You also see that pattern within the cognitive delays. You see to some extent within the language delays and also within the functional delays. I think more so in cognitive and functional delays. In fact, substantially in functional delays. More the functional delay, more the motor impairment. So then the question becomes, okay, yes, you could consider motor anywhere. You could consider it within the core impairments or criteria, or you could consider it as a specifier, and that would be valid to put it either places. Then the question also becomes what, which domains within the motor system are related to core impairments versus other impairments or other delays. And so this is where, so those 2 papers have been published. This is the paper I'm working on right now. Here, I looked at factor analyses. So factor analyses for DCDQ was done when the measure was developed for the general population. And there were 3 subdomains that were identified. Control during movement comprises of a series of gross motor skills. Fine motor is its own domain, and general coordination is a series of questions on motor competence, general motor competence. But when you do the same confirmatory factor analysis with the sample from the SPARK data set, you get a different picture. You actually get 5 factors that are important, and they look different, suggesting that motor issues in this population are different than that in a general population. And so you get CDM1. So there are 2 factors within control during movement. The first one is actually visuomotor, a series of ball skills. The second one is a series of multi-limb coordination, or I would say motor planning. This item is specifically on motor planning. And then fine motor stands on its own. Then you have general coordination 1 and 2. So these 3 questions are actually more sensitive to variations in these other system impairments than these 2 questions. They don't seem to be explaining the variation as much. Most people will say, oh, yes, I think my child is like a bull in a china shop or is fatigable. So this is the data that is presented in the previous paper were means and standard deviations for for the three main subdomains that are generally discussed within the DCDQ. So in what I've looked at now is how are the means and standard deviations across those 5 subdomains that are coming out as factors from the confirmatory factor analysis. So this is visuomotor, this is the multi-limb coordination planning, this is still the same fine motor as before, and then these are the 2 motor competence, and this one seems more effective than this one. And so here what you could look at are these effect sizes. So what is the motor difference effect size across the subgroups as it relates to social communication impairments or repetitive behavior impairments or these general delays? And what you see is sometimes motor ability does not explain the variation across these subgroups based on another domain's performance. But sometimes it does a great job. For example, here, general motor competence, those first 3 questions did a great job of explaining variation in function, motor performance or motor competence reduced over increasing levels of functional delay. And so that is what I'm looking at in this second graph here. I have plotted total scores of DCDQ, those standard subdomains of DCDQ, and also the 5 subdomains that were based on confirmatory factor analysis. And what you see here in these boxes is effect sizes. So on the y-axis are effect sizes between that first and the last group. How much variation in motor performance is explaining variation across those subgroups based on other impairments. And what you see is when you look at these 4 subgroups that are provided by the confirmatory factor analysis, for social communication impairment, all 4 motor domains do a really good job with large effects in explaining the variation in social communication impairment. And I would say it is the same. It is slightly more for fine motor, but it's pretty close to 0.8 for these other domains as well. So in terms of core impairments, both fine and gross motor impairments are explaining the variation in these other core motor impairments, suggesting that those motor issues are related to the pathology of autism. They are not some other, other pathology underlying autism. So here, I'm looking at cognitive delay. So the next row is cognitive delay, and it looks like fine motor more so, and then multi-limb coordination, motor planning, those 2 relate more to the variation in cognitive delay. And that makes sense, as this could relate to executive functioning and planning. In terms of functional delay, again, this result is not surprising. All forms of motor impairments were relating very strongly and show large effects when explaining functional delays. And lastly, you have language delay. This is also something that is known in the literature, that fine motor, and to some extent I see visual motor as well, but fine motor relates and better explains the variation associated with language delay. So overall, I think motor impairments are pervasive, they are persistent, they are related to both ASD specific and general delays, and it would be appropriate to add them within the diagnostic criteria in a future DSM. And I don't know how to go about doing that, but that's what I'm trying to explain in these papers, that people should be looking at this more carefully. Both gross and fine motor delays are related to ASD-specific impairments. Perhaps fine motor and motor planning delays were more related to cognitive delays, and fine motor and I think to some extent visual motor items were also related to language delays. And I have looked at this even at an item level, but it would be a lot of information to discuss today. So that's why I'm not going into that today. Overall, I think motor issues are underdiagnosed and undertreated in this population, and it would be worth to consider adding ASD motor issues within the ASD criteria or specifiers to improve screening, evaluation, and treatment of motor issues in this population. So that's my first third of this talk. The second third of this talk is, sorry, the second portion of this talk is looking at various interventions. So again, this all started in 2010 or so when I started my new position at UConn. I remembered what Stuart had said. So he was the person who I worked with to understand dyspraxia and autism. And so he had said that generally that is studied in autism, but we don't treat that in autism. That issue is not addressed in treatment. And the focus is usually on understanding neural mechanisms related to motor problems so that we can better explain generally the pathology of autism. But I thought that if you treat that in cerebral palsy or in any other diagnosis, you would treat motor issues that present in the child. Why wouldn't you treat it in children with autism? And so it made sense to look for more multi-system, multimodal interventions. Traditional autism interventions are intensive. They focus on social communication, academics, fine motor skills. They tend to be sedentary in nature and are not inclusive of whole body movement or movement related aspects. And so the one therapy approach that was capturing this was definitely music therapy and reviewing the literature. And so that's where we started. We started looking at music and movement and what impact that can have in children with autism. And the value, I thought, was that you don't only look at motor aspects, you could look at social communication, positive affect, positive behaviors. And so these were interventions where small group settings were used, and we were promoting social interactions, so imitation, communication, positive affect, positive behaviors, but also promoting a variety of motor skills. And so children were moving to music, they were engaging in social synchrony, and these were highly motivating and creative contexts. And in so many years of doing this, I feel that there is a lot of value in using this approach when working with nonverbal children with autism, because they do need these highly motivating contexts to engage them in social interactions, and these work. So I want to show you some videos of different types of activities we do with the children during the 8-week interventions. These are all 8-week interventions with children. And so here's an example. So there are fine motor games that relate to use of instruments, and one activity relates to drumming. Then there are action songs, there are hello and goodbye songs, and there are moving games, there are whole body movement games that promote more whole body coordination and balance. And then Mandy, who's now at MGH, did a whole another protocol using rhythmic yoga, where she used balance poses in yoga, as well as breathing and focused attention to promote a variety of skills. So I'll show you videos of 3 different contexts. So first is drumming.
Oh, that's hard. Look at the jungle. Do you hear in the jungle? Okay, let's see what Amber has to say.
I can hear the lion roar.
Ooh, that's hard. Look at what she did.
I can hear the lion
roar. Can you practice, Logan?
I can hear the lion roar.
No, look at her again.
I can hear.
Can you do I can hear?
Want to practice? Ready?
I
can hear the lion
roar. I can hear the
lion
roar. That's right.
So In the drumming games, there are a variety of contexts, but this one was looking to promote motor planning as well as bilateral coordination and also auditory motor mapping. So using words actually promote coordination, using it the other way around, the way auditory motor mapping is generally used, is movements are used to promote communication. Here we were trying to use it the other way around. So that is one. The other video is looking at whole body coordination. So the context here is they are pretending to be balloons and to sort of move in the wind, lose air, gain air, things like that. But in the process, promoting balance and coordination and imitation and synchrony.
Okay, get into a really small shape. Nice and small. And now I'm going to blow you up like a balloon. Blow up like a balloon. Get into a really big shape. Really big shape. Nice and big. Good. And then pop, pop. And get into a new shape. Pop. Nice. Now make your new shape. Good job. Now I'm going to blow you up again. And make a new shape. Good job. Good. Make your shape. Making the shape. Stay in your shape. Okay. And now you get a leak. Now can you shrink really slow? Into a new shape. Oh, find your shape. Make a new one. Get big and small on the ground. Nice. Okay, now I'm putting a patch on your leak. Alright. Now you're gonna blow up again. And make a new big shape. Alright. And now the wind is spinning you around. Oh, no. Twirl. Now can you leap? Nice. Keep spinning. And now the wind spins you quicker. Spin quick. Quickly, spin fast. Nice spin, Megan. Woo! And then you lose your patch, and then you shrink really quickly. Woo!
Right. And so this one, you see that the child is, following the other partners in the activities, enjoying the activities, and also having a non-intimidating context in which they can actually practice some of the motor skills that they might lack or some of the communication skills they might lack, because there could be games that involve singing while moving or just moving and so on. So this is another one. And the last one I want to show is how yoga can be used through partner poses to promote core strength and eye gaze, social gaze, as well as social interaction while moving.
1, 2, 3, 4, 5, 6, 7, 8.
And we would use a variety of games. So this is one pose within a whole story or a whole song or a whole, structured game that is being done, where a variety of poses are practiced or breathing is practiced or focused attention is practiced to certain points in the room or body parts. All right. And so what do we see after 8 weeks of intervention of this type? So this was a pilot RCT we did between 2013 and 2016. And so there were 2 primary groups, and then we've added the yoga group on top. And so the comparison group is the standard of care. So this involved a lot of seated play to focus on reading skills, social communication skills, fine motor skills using building, art craft, and so on. The music group is the rhythm group here in this graph. And that's the music and movement where we are focused on using a variety of songs, action songs, use of instrument play and moving game to promote both synchrony, coordination, as well as communication. And then the yoga group is very similar to the music group, but it is focused on the concept of using yoga itself. So we call it rhythmic yoga, but there is use of music and sing songs as well here. And we were not interested in looking at motor effects only because that is something that should be impacted in these different groups. We practice fine motor skills here. We practice gross motor skills here. In this case, I would say also some level of fine motor skills were practiced. But we were really interested in the multi-system effect. So we looked at these videos in terms of early and late in training, and what are we seeing as changes in verbalization. And the main changes were in their spontaneous verbalization. So that is plotted here. We also looked at imitation errors for the standard tasks that we did in an early and a late condition. Do we see improvement in accuracy of movements that they practiced during the training sessions? And then also, what is the affective state of the child? Are they enjoying these activities? What are the negative behaviors that we are seeing in these children? How does that change over time? And then within a standardized Brunig-Sosteretsky test, for a fine motor and a gross motor sub-test, what are the changes? So what we see is there is improvement in verbalization even in these movement contexts that is either equal or more than what you see in the comparison context. In terms of imitation errors, for the tasks that they practiced, they all showed improvement in imitation performance or fewer errors, erroneous components within certain complex movements that were task specific. And then in terms of affect or smile rates, how much they smile, you don't see improvements over time. So, with training, you don't seem to be smiling more. But in general, within that context, you see more smiles within those movement contexts than within the comparison group. You'd see more compliance. If anything, you see more compliance in the comparison group, not as many smiles. Negative behaviors, you actually see very little negative behaviors in the comparison group. Once the child is in the chair and pushed against the table, there is very little freedom to move around or show any negative behaviors. Versus when you're openly sitting or standing, there is more possibility of running away, and rhythmic activities were more novel to children versus the comparison group activities or skills they practice at school often. And so it is not surprising that they found this, more challenging, but that challenge did reduce over time and they did show reduced negative behaviors with training. In terms of motor skills, what we see is more task-specific improvements. We see more fine motor improvements in the fine motor group or the comparison group. We see more gross motor improvements or bilateral coordination improvements in the movement groups, which is also something we know about movement therapies. They tend to improve what you work on. Okay, so when we did this RCT and sort of tried to, go back to our program officers to see if they would fund a follow-up of this, the first thing they said is, what if these were just Hawthorne effects? That is, you went, all these great clinicians worked with these children. We don't know what the mechanism is by which movement can improve communication or behavior or affect and such. What is the mechanism? And so there were two lines of studies I have done after the first RCT. One was actually done around COVID times. So that has been a really difficult thing to do, trying to do an RCT in COVID times. So here we've tried to tease apart the key ingredients within the, we call it creative movement or music and movement in this study. we've tried to tease apart movement from other aspects of creative movement. So they still engage in musical activities that are synchronous in our experimental group, but we have two control groups now. We have a general movement group where they mainly practice activities in turns. So they take turns. They don't do things together. And when they move, they do not use music, and they mainly focus on exercises and physical activity-based games, obstacle courses, and such. And then the standard of care is actually still the same as it was in the previous study. But what also changed in no access. So we had to do things remotely, and that has definitely changed the way we have done this intervention. It is more flexible now, it is more pragmatic, and it is possible to do this through telehealth, or we can go to their home and do it face-to-face. Previously, we used to go home and do everything. We do it through the parent, or we can do it directly with the child. And this is possible for both experimental as well as comparison groups, or both comparison groups. And so that has made this intervention to some extent family-centered, because parents are involved in these interventions. They are able to tell us more about what are meaningful goals for their child. They can see their child as they are being tested and trained to see what their challenges are, and they can actually appreciate the value of the intervention much more. So what has changed over the COVID time frame? So previously we used to, as I said, the trainers had their training kits, the testers had their testing kits. We had 3 trainers perhaps, or 4 trainers perhaps, and 3 testers, and so that many kits were there. But now we've had to make a kit per child. So there are test and training kits that are packed in boxes and mailed to the family. And then we meet with the parent on Zoom, collaborate with them, explain to them how these tasks are to be done. And then we do it with them. We co-test and co-treat with them, collect those data, collect the kits back, reset the kits, and redo this whole process with every child. And so that has been challenging, but there have also been advantages to doing this in terms of getting family buy-in. So at the moment, I do not have data for these. This trial is still going on. We are almost towards the end, the last round of this trial. And so we will have data next year. So next time when I am able to come present, I can talk about those findings. So that brings me to the third part of this talk, which is biomarkers. And so here, again, when I was speaking to these program officers, the first thing that came up was, do you have neural mechanisms to explain these effects? And so this RCT, while it has been affected by the whole COVID pandemic, we were able to get pre-post biomarker data on these children. And so that is something that will be known once this study is done, whether there were treatment response effects on these biomarkers as a result of these interventions. And that was the motivation behind studying these biomarkers. Can we identify biomarkers first, and then can we use them as treatment response outcomes following a bout of synchrony-based interventions? So that's this work. And I started, as I said, this work in Kevin Pelfrey's lab at Yale many years ago, where I learned how to use the Hitachi FNIR system. And as I know that many of you do neuroimaging with Matt, and so you know that FNIRS has its flaws, which is it can only collect data on cortical activation and not anything deeper than that. And it is also the activation that you collect is a function of the way your probes are set up. And so when we started the study and did the very first task, which is a reach cleanup task, we used lateral probes only. We did not have that whole prefrontal and lateral cortex probes. So there we have fewer regions of interest we have data on. And then later on, we did what is maximum possible with Hitachi, which is their whole head probe set. And so we collected data laterally as well as the prefrontal cortices for these other two tasks. The regions of interest for us have been the social brain areas, so superior temporal sulcus, and laterally it was the inferior parietal lobes and the inferior frontal gyrus. And what's been added on when we got the full head holder is the pre-post central gyrus as well as the prefrontal cortices or the middle frontal gyrus. And so right now I have 5 of these ROIs, and for the left side as well as the right side. So what were these tasks? Why these tasks? The reason why I looked at these tasks is because we were interested in looking at what socially synchronous movement has to offer more than general movement, so solo movements versus just observing. So we do a lot of observing and sitting in our standard of care. We do a lot of general exercise and movement or solo movement in the general movement group, and then we do a lot of synchronous movement in the the creative movement group. And so that's why we've tried to increasingly add socially embedded movements across these different tasks. So for reach and cleanup, the children were first asked to just see. So these were all randomized trials. So we used randomized block designs for these experiments. And so there were conditions where they would just see the adult clean up the blocks. Then there were conditions where they would clean up the blocks on their own using their own pattern, or they would the third condition was together cleanup, which is they are both cleaning up and the child has been asked to follow the adult. And then there is the cooperative building task. So in this, we use the Lincoln log game. And so we had different configurations, final configurations of how they could build the Lincoln log creation. And they got 4 different contexts. So one was the compete context, where both the adult as well as the child had their set of blocks and their creations shown to them. And they were supposed to build that creation as fast as they could. So that was compete. Then they had lead was where the child was shown the configuration and the adult had to follow the child. Follow for the child was the adult was shown the configuration, the child had to follow the adult. And the fourth one was cooperate, where both were shown the configuration, but they had to alternate their placement of blocks. So one turn went to the child, the other turn went to the adult. So that's the second task. And the third task is a synchronous sway task, where we were trying to sort of create a task that is associated with our dance or moving game contexts, where the subject would, so this is done in children with autism. The picture is with 2 adults, but the children with autism would move with the adult experimenter. So one condition was they could move with the monitor that shows a pendulum that is swaying. So they could sway side to side with the beat and the rhythm of the pendulum shown. So the person is not in front of them. Or they could move face to face with an adult, or they could move face to face while touching the fingertips to an adult. So they're not putting weight on each other, but they are just adding the social touch condition within this sway context. And what we see is this. Sorry, there's a lot of data to cover here. I've put it all in one page. The first one is the reach cleanup task. And what you're seeing on y-axis is oxyhemoglobin concentrations, which are a function of increased activity. So if that is higher, there is increased activity in that region of interest. And so you have left and right, inferior frontal gyri, superior temporal sulci, and inferior parietal lobule. And the three different conditions are watch, do, and together. And what you see is increasing levels of activation with, so first of all, movement in general leads to much more activation, cortical activation, than observation. And social, to some extent, leads to greater activation in some areas, but not that significantly more. So that was interesting, that movement in general leads to much more activation than observation. The other finding was group differences. So these are children with autism, and what you see is across multiple regions, these red dots, which mean typically developing children, were showing much more activation than children with autism. There is one area where we actually don't see significant activation in the children with autism, typically developing children. We actually see hyperactivation in children with autism. So these are the blue dots. It's the inferior lobes where we're seeing greater activation in children with autism compared to typically developing children. So this finding is actually not new. We were able to find a lot of work, even Kevin Pelfrey's own work, showing that these areas are sensitive and socially aware. They are active when you're socially aware. And so the fact that they have less activation here is just a replication of what has been shown in neuroimaging literature otherwise. This has been a newer finding. I'm still trying to understand if this spans out across the different tasks and also in the future. But so we can look at that here. So the second task is the cooperative building task. So here again, we see that typically developing children are showing much more activation. The solid bars are higher compared to these hatched bars. In the inferior frontal gyrus, you see this. You also see it in superior temporal sulcus. The different bars are the different cooperation conditions. Blue is lead, orange is compete, and red is the cooperate, or the most socially cooperative condition, which is the joint or cooperate condition. The follow is not shown here. I was trying to keep things the same across these different tasks, but it is very similar to joint. What you see in children with autism, you see overall less activation, but you also see context-related changes, which means when they engage in joint or cooperate, they actually show less activation. They show more social awareness and activation in the lead and compete conditions. And so the discussion of this paper has been that we should be encouraging children with autism to lead and compete more, as opposed to always telling them, do what I'm doing or follow me, which is what we often do when we provide therapy to children. Perhaps they are going to be more socially aware and engaged if they are given opportunities to lead and compete. So that's that. And then again, here, the IPL region, I don't have a, completely depressed IPL here, but in the case of children with ASD, we do see more, lack of sort of change. It tends to stay on all the time. When you look at the synchronous sway data, we actually see, as we become more and more social in our movements, where we go from solo, following a pendulum on a monitor, to swaying face to face with someone, to swaying face to face while touching fingertips, you see more and more cortical activation in these regions. In the case of typically developing children. So scaling up of activation, but you don't see that in children with autism. You also see that scaling up in children with typical development in the IPL region, but you actually don't see that. It's always on in the case of children with autism. So overall, this has been the pattern. We think these are neurobiomarkers. I'm able to explain this very well. I'm still trying to figure out what this hyperactivation in the IPL region means. And we also see relations between these brain region activity and their performance, their social performance or communication performance, as well as social responsiveness. So more the activation in these regions, more the communication scores. And in both of these other tasks, the measure that has worked well is the SRS, where more the activation in these regions, less the autism severity, because higher scores in SRS is higher activity. Sorry, higher scores in SRS imply higher autism severity. Okay. And so the next thing we are doing is taking neuroimaging into the community. So we found that it was hard in the COVID times to bring families to the lab. So we've been using a lot of portable neuroimaging, Shimadzu light nears and Nirex near sport, and hoping to do more of these imaging data collections in the community. So overall, this is my sort of spiel, my message for you. We should be considering motor issues within the definition of ASD. We should be using multi-system interventions that are inclusive of movement as well as other domains while providing interventions to this population. FNIR's biomarkers seem to work. Whether they are treatment response measures for such interventions remains to be seen, and perhaps they can be used in more pragmatic and community-based contexts. And so that can be an extension of neuroimaging within the community. Be more flexible, pragmatic, and family-centered in your research, and try to bring neuroimaging into the community. Try to make it user-friendly, because it was really, that was the lesson I learned, I think, during COVID times. Thank you.
Anjana, thanks for a great talk. You really presented a lot of data, and so I know I'm still trying to process some of it, and I'm sure others are as well. But I do want to open it up to questions from the audience. Feel free to unmute yourself and ask Dr. Bhat directly.
So this is Steve Warren. This is a great presentation. So I'm an old guy, so I remember running around with kids who had developmental disabilities. We didn't call them that, say that even. We had other names, but and the behaviors were always ignored. It seemed to me, unless they were just really, really super bad. It's sort of taken a long time in a way. I think your program is really impressive, but it's sort of taken a long time to kind of figure out how to get into this, it seems to me.
Sorry, I think he got cut off. Ah.
That was sort of a question for you.
Sorry.
Steve, I think there was a little technical issue at the end. You said that it's taken a long time for the field to adapt or recognize the importance
That's how motor skills are. It seemed to me it was always the part that was kind of left out. Well, they kind of do this, but we're focused on language, we're focused on cognition, we're focused on things like that. And it just sort of seems like it languished for a long time. Obviously, you've been doing a lot of work on this for a very long time, but that's good.
Yes, absolutely. So before getting into autism, the field I was in, or I'm still in, not was in, is infant motor development. And that's how it's been even with infancy researchers. Motor development is always considered like the easy thing that doesn't need to be studied. So I think that trend just continues. Cognition and language are just considered these higher order skills that we need to pay a lot of attention to. Motor gets ignored in general when studying child development, and maybe that is continuing within autism itself. But I also think there are just so many challenges in children with autism, right? Our communication is so significantly affected, and so are the behaviors. And so parents are looking for, okay, there is some strength somewhere. Tell me that there is some strength somewhere. And so, they are so much focused on these core issues that are a challenge that something gets ignored. But the point I'm trying to make in those interventions is that you don't have to ignore it. You can use a multi-system approach and actually tackle multiple issues at the same time.
So when I was watching some of your tapes, I mean, to me, it looked like you were getting social and some communication stuff in those things that you were doing with motor. It was having to a large extent, or medium extent at least.
Yes, and that's where I'm trying to explain why that is the case. There is a lot of literature in infancy, again, infant motor development, on how motor can have cascading effects on other developing systems. And that's what we were seeing here. We see a lot more enjoyment and spontaneous communication when you engage in these more multi-system interactions. Sorry, I don't think he can hear me.
You're fine.
Yeah.
It makes sense, but it really was ignored for such a long time.
Yeah, I agree.
Sorry. I was just I had a quick one over chat that I want to throw in there really quick, if you don't mind.
Yeah, go for it.
Renee Jameson sent a couple of questions, actually. One, kind of her classic question of if you saw any gender differences in your results. And her second question was wondering if you have tried to do any of these tasks where the participants worked with peers in terms of similar age peers rather than adults.
Yes, absolutely. So great question. So first one is on gender differences, and this is reported in that first paper from the SPARK data set. So when the comparison group that I use for the SPARK data set is a general population data set that is out there for the DCDQ, which had presented means for all different ages, males and females. And that showed that in general, both males with ASD and females with ASD are very different from their typically developing counterparts. They are fairly below in terms of their motor performance. But if you just look at how motor performance changes over development for males versus females with ASD, you see that the motor delays are reducing in the females during teenage years. So there is a trend there showing that motor issues are improving